Dear colleague, welcome. In this video, I would like to share two real and educational radiologic cases from head and neck imaging that share the same final diagnosis. These cases are especially relevant because they illustrate classic imaging features of a common orbital vascular lesion and highlight key points for radiologic interpretation in daily practice. Let us begin with the first patient. This is a 45-year-old man who presented with right-sided ocular ptosis. Based on the clinical findings, a contrast-enhanced computed tomography scan of the orbits was requested for further evaluation. On the axial contrast-enhanced CT image in the soft tissue window, we can identify a well-defined, oval-shaped intraorbital mass located within the intraconal space of the right orbit. The lesion demonstrates soft tissue attenuation and shows focal areas of enhancement after contrast administration. Importantly, there is no evidence of bone infiltration or destruction, no extension beyond the orbital boundaries, and no intracranial extension. On the coronal reconstruction of the same contrast-enhanced CT study, the lesion is again clearly visualized within the intraconal compartment. At this level, the mass effect on adjacent orbital structures becomes more evident. The lesion markedly compresses the medial rectus muscle, which is nearly effaced when compared with the normal appearance of the contralateral medial rectus muscle. There is also mild to moderate compression of the inferior rectus muscle, which appears slightly deformed due to extrinsic pressure from the lesion. In addition, attention should be paid to the optic nerve. When compared with the normal left optic nerve, the right optic nerve is displaced and compressed by the mass, with superior deviation. These findings explain the patient's clinical presentation and demonstrate how intraconal lesions can affect both extraocular muscles and the optic nerve. Before discussing the diagnosis, let us move on to the second patient. This is a 49-year-old woman who presented with blurred vision. In this case, the available imaging study is a magnetic resonance imaging examination of the orbits with axial T2 weighted sequences. On the T2 weighted images, there is a well-defined intraorbital mass located predominantly within the intraconal space of the right orbit with a possible minor extraconal component. The lesion is oval in shape and markedly hyperintense on T2 weighted images. A thin peripheral hypointense rim is visible, consistent with a pseudocapsule. The lesion produces mild extrinsic compression of a globe, with slight flattening of the posterior scleral contour, as well as associated ptosis. When comparing the optic nerves, the left optic nerve appears normal and centrally positioned, while the right optic nerve is compressed and displaced medially by the mass. The final diagnosis in both patients is orbital cavernous hemangioma, a term that is historically used but technically inaccurate. The correct and preferred term for this entity is orbital cavernous venous malformation, as this lesion represents a vascular malformation rather than a true neoplasm. From an imaging perspective, orbital cavernous venous malformations classically present as well-circumscribed, solid intraorbital masses, most commonly located within the intraconal space, often lateral to the optic nerve. They typically have an oval or round configuration and well-defined margins, as demonstrated in both of our cases. On CT, these lesions usually show soft tissue attenuation and demonstrate enhancement after contrast administration. On dynamic studies, enhancement may be heterogeneous in early phases and become more homogeneous in delayed phases. When large, they may cause smooth bone remodeling, but they do not produce bone destruction, reflecting their benign nature. On MRI, these lesions are characteristically hyperintense on T2 weighted images and may show internal septations in some cases. A peripheral hypointense pseudocapsule on T2 weighted images is a helpful diagnostic feature and was clearly demonstrated in our second patient. From a pathophysiological standpoint, it is important to emphasize that this lesion is not a hemangioma in the true sense. Unlike hemangiomas, which are tumors, cavernous venous malformations consist of dilated vascular spaces lined by endothelial cells and represent a low-flow venous malformation of the orbit. Clinically, orbital cavernous venous malformations are the most common orbital vascular lesion in adults and are more frequently seen in women. They may enlarge during pregnancy and typically present with slowly progressive, painless ptosis. In many cases, they are discovered incidentally on imaging studies performed for other reasons. Management is usually conservative, and surgical treatment is reserved for patients with significant ptosis, visual impairment, or optic nerve compression, as illustrated by the mass effect observed in both of our patients. Before we conclude, if you are interested in temporal bone imaging, I invite you to watch another video on this channel titled Otosclerosis Imaging, CT and MRI Key Radiologic Findings. You will find the link to that video in the comments section below. Thank you very much for watching. If you found this case-based discussion helpful, please subscribe to the channel Dr. Martin, Head and Neck Radiology, give this video a like, and leave a comment below. Your support helps the channel continue providing high-quality educational content for radiologists and healthcare professionals worldwide.